This is the right shoulder in a 60-year-old patient. Patient's in the lateral position, and you can see there's considerable exposed footprint and at least a posta lesion, possibly a full thickness lesion. As we view more posteriorly, you can see the infraspinatus is intact, and inferiorly the teres minor is intact with minor fraying. Some chondromalacia is noted on the humeral head, and the biceps tendon looks relatively normal. So we'll start out by inserting a PDS suture percutaneously through the bursal side of the lesion into the articular side, so we can judge the bursal condition of the tendon and decide how to effect our repair. We're also going to need an anterior portal, and this anterior portal is a high anterior portal just adjacent to the biceps, because we're going to need to be able to get above the biceps parallel to the tuberosity surface. We'll debride the tuberosity down to a bleeding cortical surface and do some cuff debridement too, just so we get some stem cells into our repair. Now here's the tendon we have, and after debridement you can see it is a full thickness tear. But since it's non-retracted, it's still an excellent candidate for transtendon suture and anchor placement, and we can use it to demonstrate the principles of a transtendon posta repair as well as a double row full thickness repair. To perform our transtendon repair, we need to get back into the joint and view from the posterior portal. And it's very helpful to view from the anterior portal and place a switching stick through the previously made portal hole, and then we can follow the switching stick with the actual cannula so we don't have trouble getting back into the joint from posterior. So we use the 1.3 millimeter Y-knot percutaneous cannula system, which allows us to pass a 1.8 millimeter Y-knot anchor from which we've removed one of the sutures. One of the main advantages of the transtendon technique is that it allows very anatomically correct placement of the anchor and the sutures through the cuff. The spinal needle guide should just catch the lateral edge of the avulsed capsule attached to the cuff tendon to anatomically restore it to the medial edge of the tuberosity footprint. We'll follow the spinal needle with a guide wire, and then the guide wire is followed with a dilator, and finally the dilator is followed with the actual 1.3 cannula. Then the cannula is maneuvered to within 1 or 2 millimeters of the articular margin of the humeral head, and you need to make sure that the angle is safe so that the anchor will not penetrate through the joint surface. The spike cannula is set, and then we'll drill down to the external stop and then insert the anchor, and then set the anchor by pulling on the sutures, and then retrieve one of those suture limbs out the anterior portal. We use a spinal needle for a retrograde passage of the other limb of the suture, and the same principles apply of correct placement of the spinal needle right at the lateral edge of the avulsed capsule attached to the rotator cuff tendon. In this case, we're using a PDF suture as a shuttling device to bring the other limb of the anchor back through the cuff, but a shuttle relay works very well in this instance also. You can see the PDS shuttling the suture back through the cuff, and then we'll begin the process of placement of the second anchor, and the same principles apply, being just on the lateral edge of the avulsed capsule, being close to the articular margin of the humeral head, and watching our insertion angle. And we'll pull back one limb of the suture, once again through the anterior portal, use our spinal needle to determine suture placement for the other limb. Again, too medial and will be too tight, too lateral, and the repair will be non-anatomic. And so here is our final view of anchor and suture placement on the articular side, and then we'll go back into the bursa and tie the mattress sutures to hold down the medial row. And if this was a transtendon posta repair, that would complete the repair. But in this case, since this is a full thickness tear, we're going to use a poplok anchor to complete a double row repair and anatomically hold down the lateral edge of the tendon on the tuberosity. So we'll start with the dilating trocar for the poplok anchor, and we'll bring that in directly through the lateral subacromial portal. Sometimes you need to do some debridement and cleaning out of the lateral bursal tissue in order to provide direct visualization for this process. The poplok's inserted down to the laser mark, And then we're going to tension the sutures. And you want to be careful not to over-tension the sutures for the lateral part of your repair. You don't want to crush or devascularize the tendon. The poplok is deployed and the sutures are cut. And here we have the completed repair as viewed from posterior. And now we'll take a look at the repair from the lateral portal. And we've got good medial and lateral row fixation and an anatomic cuff repair.